Are you looking at enough things to comfortably say somebody is ready to return to sport after a patellar dislocation? We have two separate patients at two different locations at R2P right now that I actually got to interact with the PTs in the same day on how they're progressing and what their return to sport discharge testing is going to look like. So I think when we have a patellar dislocation and it's been deemed that it is one that can be a conservatively managed case and does not need to undergo an MPFL reconstruction or any surgical reconstruction to stabilize the joint, we need to make sure that we're checking all of the boxes in regards to things that can influence the likelihood of a successful return to the playing field. So with both of these individuals, they are both field sport athletes, one being football, one being soccer. But with these athletes, things that we need to look at come in a variety of shapes and sizes. So we need to make sure, one, do we have symptom profile under control? Meaning they should be asymptomatic or they should have an extremely predictable symptom profile. And largely, they shouldn't have any reactive stiffness, swellness, or inflammation just from their day-to-day activities or whatever their desired activity is going to be when they go back to playing sports. If they're still highly symptomatic or even moderately symptomatic, I'm not sure what their long-term success is going to look like with that. So making sure symptoms are under control, making sure that range of motion is under control, and back to what it was pre-injury. And not only having this range of motion, but can we demonstrate competence and control with it? Do we have extension or maybe even hyperextension if that was present before the surgery, or I'm sorry, before the injury? Do we have full flexion? Do we have pain-free flexion in both supine and prone positions? Can we access that amount of flexion in not only non-weight-bearing table testing positions, but also on our feet in a weight-bearing environment as well? So getting into different deep squatting variations in bilateral, unilateral, and asymmetrical tasks with that as well. From a strength standpoint, this is where we need to make sure that we're checking a lot of different boxes off. Do we have good relative strength, just in regards to being able to manage our own body weight and doing that in a variety of planes and a variety of types of motions, with hinging patterns, with squatting patterns. Things that we will commonly do for this is an isometric expression of body weight competency. So can we do a single leg wall sit, progressing down to a 90-degree knee flexion angle and maintain for 30 seconds? Can we do that without pain at the patella? Can we do that just feeling our quads working and no excessive symptoms being provoked from that? Then can we demonstrate that static stability with our body weight and show it in a dynamic task? So doing something like an anterior step down, placing them on a 6 or an 8-inch box and having them do an anterior touchdown, tapping their heel to the ground for as many reps as possible in a given time frame if we're looking for performance. Or can we set them to a consistent cadence, maybe to the beat of a metronome, and seeing can we keep that beat for an extended period of time, and can we do that with quality movement without producing symptoms or compensatory strategies, and does that look similar between the two legs? We can also look at strength testing with regards to just knee extension strength. So maybe in our clinic we hook them up to a tin deck, or you could hook them up to some form of handheld dynamometry and get an isometric expression of peak strength at a specific knee joint angle. So maybe we're looking at this at 60 degrees, 90 degrees, 30 degrees at various angles, making sure we're not having any instability, making sure we're not having pain. More importantly, or just as important, making sure that we are having symmetry between the two limbs, but we are also having good output in regards to our own body weight as well, and making sure that we're normalizing that data that they're getting from a peak force production in relation to their body weight and getting what that ratio is. Other things we can look at strength-wise, just common weight room metrics. What does their back squat look like? What does a front squat look like? Two things that we like to look at: a rear foot elevated split squat and a lateral box squat. These give us a sagittal plane profile and more of a frontal plane profile, where we can look at linear and lateral loading to the knee. We can add external load in addition to our body weight in the form of a kettlebell, a barbell, or dumbbells, and we can see how much weight can we do for a given amount of reps. This can give us an idea of what their strength is, or maybe their strength endurance, if we utilize a certain rep scheme with that. And that also gives you the ability to look at one leg versus the other to see how the injured leg is doing in comparison to the contralateral limb. We need to also look at their movement quality. So with all of these tests, we can also quantify, not only quantify, but qualify their movement in regards to how does it look, and are they performing these tasks in a manner that looks appropriate given the demands of the task. We need to also look at their plyometric abilities. So pogo testing, where they are doing kind of an ankling motion in place in a two-footed and a one-footed environment, gives you an idea how much stiffness they can create at the knee. Are they able to get on and off the ground at a specific cadence for a specific time without fatiguing or having a degree of instability at the knee? Is the knee giving way? Is it buckling? Or can it tolerate that quick impact and impulse coming on and off the ground? We can then look at different horizontal and vertical hopping profiles with either a broad jump or a vertical jump, and we can do that in bilateral and unilateral fashions as well. That gives us an idea of what their overall power production is. It also gives us an idea of how well they can not only jump and produce force, but how well can they absorb force, and are they able to do that competently and confidently as well. In addition to these tests, we also need to be looking at their overall strength and conditioning and general fitness profile. So finding some way to measure their aerobic fitness and some way to measure their anaerobic fitness. From an aerobic standpoint, you should have a good idea of what they're capable of doing just by their ability to carry out a full 30, 60, 75, 90-minute exercise session that you're either taking them through in the clinic or that you're prescribing for them to do outside of the clinic as part of a home program. From an anaerobic standpoint, something that we like to look at is a 300-yard shuttle. So we're fortunate enough to have turf that's 25 yards long in our clinic, and we can have them do shuttle runs. Down and back would be 50 total yards. Down and back for 6 laps would be 300. We can see what their total time is, how that looks compared to others who play the same sport and are the same gender and age as they are. But it also gives you an idea of how well can they change direction, accelerate and decelerate, not only when they are fresh, but on that 4th, 5th, and 6th lap when they start to get a little bit fatigued as well. All of those different tests give you an idea of different qualities that you can test. Symptomology, range of motion and mobility, strength with body weight, strength with external load, bilateral and unilateral nature, their plyometric component, their energy systems, their overall fitness levels. We also need to be putting them through sport-specific movements in the clinic and guiding them through what a logical return to play outside of the clinic looks like. How can we get them involved with their warm-ups, with their conditioning, with some of their skills and drills or more fundamental aspects of practice that do not require competition or do not require contact? And then how can we gradually integrate them back into maybe controlled contact drills, and then some short-sided, odd, even number situations, eventually live scrimmaging, and then finally after that, participation in games as well. So that is not an all-inclusive or exhaustive list of things that we need to look at, but hopefully it brings to light that we need to be looking at their readiness to return to sport and their preparedness to return to sport, not only just by the timeline that has elapsed since the time of the injury, not only from just our traditional orthopedic measurements, maybe circumference measurements for swelling, goniometric measurements for range of motion, some of your manual muscle testing. Those are all great things to incorporate in early phases, maybe later on as you start getting into some of the mid phase of rehab. but we need to be pushing them and doing some things that are going to truly test their ability to tolerate returning to sport at a high level with a high degree of success and confidence. So hopefully this gives you some ideas on what we utilize at R2P, but keep in mind, you can cater those tests and you can modify what you look at and be selective with what you look at based on the individual that you have and what they're trying to return to, and also just your own clinical environment, setup, and resources that you have to utilize.